Okay, so I just want to start off by explaining what a sexual health physician is. Put your hand up if you know what it is. No, it's okay. Oh, okay, one. All right, we've met before. So, sexual health is a branch of medicine that deals with sexual and reproductive health care for men and women over their lifetime. So, it's a bit like gynecology, but no operating. It's endocrinology, but it's just the hormones of reproduction and like testosterone and estrogen. It's a little bit of public health. It's a little bit of epidemiology because that's about understanding how things affect people across the population. And increasingly for me, as I get older, it seems to be about menopause. It's an interesting thing that patients are getting older with me. It's also about talking then, if we're talking about hormones and we're talking about reproduction, then we often talk about sex and we often talk about intimacy as well. And so working in the breast cancer space has been a particular area of interest of mine over the last couple of years. My best friend, my mother-in-law, my sister-in-law have all been living with breast cancer, and so this is something that is very close to my heart. Thank you very much for the opportunity to talk with you today. Now, I am fairly frank in my discussions, if you haven't worked that out already. Last night I managed to horrify or educate, I'm not quite sure, possibly both, the wait staff. So I'm kind of set to do it again, and if there's any kids in the pool that can hear me, hey, great, all good. Their poor parents. Now, one of the things that is often an issue for people going through cancer treatment is how high a priority sex and their intimate lives are at this point. For a lot of people, it's the last thing that they want to be thinking about. They have other things on their mind. Sometimes, however, for their partners and sometimes for patients themselves, it's actually even further up the list of priorities because it's about connecting with who you are as a person, remembering who you are as a woman, remembering who you are as a partner, and feeling that connection and love and togetherness. That is the reason that we all work so hard to be human beings. If we, the things that we've learned about COVID is that actually we need the connection. We need to be close. We like to be able to see people face to face. We like to be able to be in their presence. And so that connection is hugely important. I'm going to direct you to some resources as well beyond this talk today. And so Esther Perel, I think, is absolutely an amazing psychologist who works in this space. Anything she's written, shopping list, you name it, read it. She's got some great TED Talks as well, so really easily accessible and really good to watch with your partner. Because what you can then do after watching a 20-minute TED Talk about sex and relationship and intimacy is use that as the springboard for your own discussion. So what had resonance for you? What made sense to you? What you don't feel applies for you? It gives you somewhere to start to have that conversation. Because what sometimes happens, particularly in long-term relationships, is that, libido and desire changes. And, we say we're too busy and there's too much going on and there's lots of other things to do and different priorities. And then with the demands of a cancer diagnosis and all of the extra stuff that goes with that, then intimacy can be even further down your list of priorities. And we've heard, our previous speaker talking about how much medical touching goes on in this process. And one of the things that makes intimacy and sex so difficult at this point is that you feel like you've often handed your body over lock, stock and two smoking barrels to the doctors. So everyone's doing stuff to you. None of it's very nice. None of it's about pleasure. And some of it also makes you feel like you don't really have control over your own body anymore. And it's a bit like the experience of when you've got really little kids or just having had a baby, which is often a period of time where women feel like their libido wanes, is because you just want your body back. For the love of God, leave me alone and let me have my own stuff back. And that can be key to being able to rebuild some desire and libido. But it's not just about time and busyness, because it's about emotional space. I mean, for a lot of people in a long-term relationship, your intimate life will have a kind of script or a kind of dance to it. So he does this, you do that, you got 6 moves, 12 minutes, you're done. Maybe something special for Christmas and birthdays, You know, it's comfortable, everyone knows what to do, it's reassuring, it's fine, you don't need to talk about it, you've all agreed already that that's how it goes. That's all good, except the music has now changed. So that dance that you used to do doesn't go to that music anymore. It's got to be completely different. And we don't teach people, to talk about what to do when sex has got to be different. We have this erroneous assumption that sex is going to stay the same across your long-term relationship, no matter how long that is. And that's absolutely ludicrous, because there is no way the sex that you are having in your 20s or 30s is going to be the same as the sex in your 40s or your 50s or your 80s. It shouldn't look the same. It can't. Your body's going to be different. So being flexible intellectually, not so much necessarily physically, but that can be an issue as well. It's about the mental flexibility that's required to adjust, to do this dance a little bit differently, and not to panic just because it's different. We panic because sex is actually quite high stakes. It's nothing frivolous. It's nothing unimportant. It's not just some other thing that's not actually really important to people. It is about joy and pleasure and connection. And when it goes wrong, we panic, because deep down we think it means that if we're not having sex, then we're not loved and therefore we're being rejected. And that is kind of the core issue, is that fear of rejection and that fear of loss. And being able to understand that can help us to work towards a solution. So we know that at the beginning it's important to adjust to the shock of the diagnosis and kind of work out what you're going to do next and how is this going to look and what's going to happen with work and what's going to happen with the kids and who do I tell and who do I not tell. And again, as we've talked about, it can be very difficult to talk to people that are close to you, because sometimes the thoughts that you have are really dark and they're scary to you, and you don't want to burden the people that are close to you with those dark thoughts, and then they don't necessarily have the skills or the training or knowledge to know how to respond, and so nobody's talking to anyone. And so I would strongly encourage everyone who's living with cancer to be able to get some help. Don't wait until it's broken or there's a crisis. It is not a sign of weakness to get some professional assistance for maintaining good mental health. Our job as clinicians is to be prepared to help you through those darkest hours. We have a plan B and a plan C and a plan D. That's our jobs. And we love to help. Talking about sex is often the elephant in the room, and there's a lot of research to say that actually patients really want to talk about sex and intimacy to someone, preferably a doctor or clinician, but they're waiting for the doctor to bring it up, and then the doctor's sitting there going, I know that she probably wants to ask me about this, but I don't really know how to do it, so I'm just going to pretend it's not happening, and then everyone pretends it's not happening until then they land in my clinic. Now, I've got the medical oncologists and surgeons in Adelaide where I trained, pretty well trained, actually. So they know that I'm around, they know that I can see patients, they know that I can help, and sometimes women will tell me that as soon as I mentioned my vagina to Dr. Rowett, he handed me your card really quickly. Bless. Not everyone is as, blessed with the lack of frontal lobe that I seem to have developed. I blame it on reading the Dolly magazine when I was a teenager. My dad used to confiscate it from me, and as an act of rebellion, I think I've ended up doing this. So there you go. Sex is actually quite complicated. Just because it's natural, we think that it's easy and straightforward, but the amount of the state of sex education and relationship education in Australia is absolutely diabolical, and it's actually not very good really anywhere. We don't teach people that sex is complicated and it takes time to learn. We spend longer teaching people how to drive, but we don't seem to take any focus on something as complex as this. We need to be okay to talk about how our bodies change, what's working, what's not working, and how things need to be different. We're okay to talk about bad backs and bad knees, and we're okay to talk about other side effects of cancer treatment, but we're not okay to talk about dry vaginas. We're not okay to talk about penises that don't work. And I find that that's still really problematic. We need to work past that. I think a lot of people think that I spend all of my time in clinic discussing this, the physicality of sex. That's usually not the issue. I did once get a referral from a surgeon who said, please see this lady and tell her what positions to have sex in now that she's had breast cancer. And I'm thinking, it's not how it works, love. You poor thing. It's about helping to have people to have the conversation to say, I am now missing a breast, or my breasts don't respond as they used to. They used to be a source of pleasure, and now there's a scar and I don't feel anything. And I don't like the way my body looks. That's what we need to be able to talk about, and that's what we talk about in clinic. And we take the focus off penetration. Because sex is not just penis-vagina intercourse. It is about the pleasure of two bodies being together and two people being together. And you've got more to work with than just, this and this. Like, think outside your bikini area. And human beings, I think, are incredibly resilient, and we can learn new ways of doing this. And there are actually strategies that we use to help you to do this. And so in the spirit of that, we're going to do a little bit of sex therapy now. Right now. Don't panic. It's okay. I'll be gentle. So this is the kind of stuff that I do in clinic with men and women all the time. Has anyone heard of Gary Chapman and the 5 Love Languages? Put your hand up. Yep. So excellently, elegantly simple idea. This guy is a marriage guidance counsellor from the US who came up with this idea that we've got different ways of communicating our love and regard for the people around us. And this is not just in our intimate relationships, but also in our family relationships, in our friendships with our kids. And so the idea is that there are some people prefer words of affirmation. So they're the people that, write really long birthday cards with lots of nice words and send you beautiful text messages and leave little sticky notes everywhere. That's how they say, I love you. And there are some people for whom time spent is really important. And there are some people for whom presents are absolutely the bee's knees. Like getting a gift is the physical representation that there is love and regard and affection and that they are valued. For some people, it's acts of service. And for a lot of men, acts of service is what they do. So a friend of mine, her husband, always fills her car up with petrol. That's his little act of love. She hates going to the petrol station. Petrol, smells. She doesn't like it. She did also put diesel in the car. So he does that for her all the time. Doesn't have to be asked, just does it. And he's not doing it because he thinks she's incapable. He's doing it because she knows she doesn't like to do it, and without having to be prompted, he does it. That's him saying, I love you and I value you. But the problem is, if the person on the receiving end of that doesn't hear it, doesn't see it, doesn't interpret it as love, then they miss it and they just think, oh yeah, that's just, you should be filling the car up with petrol for me. It's like cooking a lamb roast. I hate lamb roast. My husband loves it. Every now and then I'll do a lamb roast. Because that's me saying, I know you really like this and this is really important to you, and that's me saying I love you. But the problem is we tend to do the things for other people that we actually want for us because we can only think from our own perspective. So that's where the wires get crossed. And the physical touch aspect of this, you'll notice it's physical touch. It's not sex. It's physical touch. So the little exercise I like people to do is, and I hope you can all do this when you go home or over the next couple of days, think about your top 5 in order of priority. And don't give me any of this, oh no, they're all the same to me, it's acts of services first. No, if it's about presents, put the presents first. It's okay. Because they don't always have to be big presents. And then I want you to try and guess your partner's top 5. Do it like a little exercise. And then see if you got it right. Swap the pieces of paper and see if you understood where your partner is at and whether or not they understood where your partner is at. And then I like to do this exercise as BC and AC. So before cancer, after cancer, before kids, after kids. because at all of those big junctions, those big changes in our life, these things will change. Humans are adaptable, flexible. If you're going to stay together, you've got to be able to bend with the wind, as it were. And so a healthy marriage or a long-term relationship will adapt. If you are still the same way that you were when you're 20, then you're probably missing out on a whole lot of really good stuff. And use positive reinforcement. So if your partner didn't get it right, don't say, oh, you doofus. You know that. God, how many times have I told you? Talk to your partner in the same way that you would a young child. You do that with kindness, you do that with love, you do that with encouragement. You say to them, oh, you've picked up 2 pieces of Lego off the floor, darling. That's fantastic. There's still 400 on the floor. And God knows where the remote controller's gone. But you still say, that's great, job well done. Everyone responds to positivity and kindness. It's an important part of having these conversations. So there you go. You've just done your first bit of sex therapy. Didn't hurt a bit. Alain de Botton is a philosopher who has written a lot of stuff about art, about architecture, about relationships, and particularly from a psychological or a psychodynamic point of view. So understanding attachment theory and how we learn about love, because we learn about love in our families of origin and then we repeat those patterns, rightly or wrongly. So he's written a book called The Course of Love, and it's a novel, but there's lots of kind of theory interspersed in it while you're not really looking about what happens in a long-term relationship over time. And I think that's a really useful approach. Esther Perel tends to take a sociological approach and a cultural approach, and this is more a psychological approach. So different things for different people. The other strategy that we use in sex therapy, which I suppose is a little bit more applied or a little bit literally hands-on, is a strategy called sensate focus. And I haven't included slides and details about it today because last night literally there were actually kids in the pool and this is not an enclosed space. The sensate focus is a strategy developed by Masters and Johnson. So that was a couple, male and female, gynecologist and his secretary, very clever woman. They got together, as you do, apparently, and they then did fantastic research about sex and particularly the physiology of sex. So they put women in CT scanners and measured what happened to their pelvises when they were aroused and what happened in your brain changes in an MRI when you were aroused. So what we know about the physiology of sex, we know a lot from them. And the sensate focus, again, you can easily Google it and find a PDF discussion point that talks you through 5 stages. And it's the way to relearn the dance. And so this is how I talk about it with patients in that, okay, so you've been doing that dance for this long. We're going to start the dance again. And so this strategy, which starts with non-erotic touching, just touch, is a way that you kind of relearn a dance. You kind of reprogram it. So it's got 5 stages or steps. And the idea is that you work your way gradually through each stage as you feel comfortable as a couple. So everyone knows what the expectations are, what's going to happen in that encounter, and what the outcome is likely to be. So it helps you to have a framework for starting again. And that can be a really useful way to relearn a new dance. Just kind of as a side sort of step from this, and because all of these things are interconnected, mood concerns can be a big issue when people are progressing through their treatment. And I think it's important to understand the difference between feeling demoralised and overwhelmed and, oh my God, this is enormous. How do I manage all of this? And whether or not you might actually be in the territory where depression is starting to be a feature and maybe medication, maybe formal mental health support would be really appropriate. And so the difference between being depressed or being sad comes down to this sort of these 2 basic points. So we talk about guilt. If you are constantly feeling guilty, I'm not good enough, I'm not trying hard enough, I'm letting everyone down, I'm a burden on my family, all of those guilty themes, if that's the stuff that's in your thoughts, then you might be depressed. If you have lost pleasure in things that you normally enjoy, so your hobbies, your activities, the sight of a sunny day, a beautiful beach, the things that would ordinarily give you pleasure, then that lack of joy, that anhedonia, as we call it, is a sign that you might be depressed. And that would be perhaps something that you take to your GP or your medical oncologist or your psychologist and you say, I think I might be depressed. I'm feeling guilty. I don't enjoy things in the way that I used to anymore. This is not just me being sad or trying to work out how I respond to cancer. And I was thinking about this because it can often be a difficult discussion to have with patients about when medication for mood is appropriate or not. And again, I'm going to tell you a little story about my dad. I'm not oversharing. I've been trying to learn how to swim recently. I learned to swim as a kid, but I can kind of save myself, but, nothing fabulous. And I thought, no, I need to learn how to swim properly because I'm also trying to learn how to surf. That's another story. And so I haven't been very good at the swimming and struggling with the breathing and the timing. And my dad said to me, well, why don't you use flippers when you swim? I said, because I don't want to use flippers. I want to do it properly. And he goes, yeah, but you've got to concentrate on your breathing. 1, 2, breathe. 1, 2, breathe. He said, take the pressure off yourself and just wear the flippers. So to his perfectionistic, overachieving daughter, he said, wear the flippers. I wear the flippers and it makes it so much easier because I glide along and I can actually concentrate on my breathing. And if I concentrate on my breathing, I can get to the end of the pool. And we've got to think about mental health support and medication as just like using flippers when you're learning how to swim. Eventually, I'll take the flippers off. I'm not sure when that's going to be, but right now I'm just enjoying getting to the end of the pool and not drowning. Go, Dad. Yeah. He doesn't remember confiscating the Dolly magazines now. I've challenged him and says, I didn't do that. You did. Anyway. Another strategy for dealing with demoralisation is to think about all of the achievements that you've had. So this is a cognitive behaviour strategy. So you think about, we think about our thoughts and our beliefs and our behaviours, and so many of them are automatic. And if you think, I can't do this, then challenge that with the evidence of all the things that you have actually done. So the best way to counter the belief, I can't do this, is to write down a list of all the achievements, no matter how big, how small. You've got a beautiful garden. You make a great pavlova. You've got great friendships. You're proud of the work that you've done. It's a beautiful day. All of those achievements and write them down, because then when someone says to you, you've got this, well, actually, yeah, I do, because I've got proof. I've written down the proof that I've got this because I've had it before and I haven't lost it. Losing a breast has not changed the person who I am on the inside. Take pleasure in small things. It can be just as simple as having your toenails painted and looking down in the shower and go, oh, geez, my toenails look nice. This is a big thing in Adelaide. It's probably not such an issue here, but in Adelaide for 3 months of the year, it's freezing cold. You could go 3 months and not even see your legs or toes if you don't want to. I still paint my toenails in winter in Adelaide because I see them and it makes me happy. If your body has changed and your clothes no longer fit, then get new clothes. There is nothing more depressing than clothes that don't fit you or don't suit you anymore. And if you're worried about how you look when you're out and about, then just, as Julia Roberts said in Eat, Pray, Love, get bigger pants. Get things that fit you. Take the old stuff, donate it to someone else that might need it and will appreciate it, and get some new stuff. You'll feel better. Surround yourself with people who get you. And think about those random acts of kindness. So this probably represents absolutely where I am right now, but this I think is a trick for all of us, and particularly for the healthcare professionals in the room, for whom, we hear these stories every day, and there is a burden and a responsibility that comes with that. So self-care is important for people having treatment. It's important for people providing the treatment. And so one of my little current tricks at the moment is if I see someone out and about who looks great in an outfit, So it started, I saw this woman who was in the supermarket and she had that whole rockabilly 1950s thing going on. She looked fantastic. I could never pull that off. I'd love to, but, I can just imagine the face of my receptionist at work. But anyway. And I went up to her and I said, "You look amazing. Well done." And I could see that I'd made her day. And I thought, I think you're onto something there, Tonia. And so now if I'm out and I see someone who's got an amazing coat or a great handbag or is obviously taking care, I just go up and tap them on the shoulder. "Excuse me, you look amazing. Well done." And it literally lights up people's face. And it also brings me joy. And it doesn't cost anything. I don't have to go out of my way. I don't have to do anything special. I just have to make a little bit of effort to be kind. It probably tells you that, I'm slightly obsessed with shoes and clothes. Again, this is my act of kindness. So this is my bias. So you will all have your own biases and your own ways of finding little ways to give kindness and then also receive it at the same time. Buying the Big Issue magazine, that can be a fantastic way to give something back to the community. If you don't know what the Big Issue magazine is, Google it. I'm conscious I don't want to run out of time. Body image issues. Again, if you need to cheer yourself up, Celeste Barber. That woman is amazing, absolutely amazing. So that's one of the Kardashians. I don't know which one. My eyes water with pain just looking at that arrangement of how that would work. Celeste Barber, I think that's a little bit more realistic. So if you're feeling a bit shit about how it's all working, get on to Instagram and have a look at some of her stuff for a couple of minutes. You'll feel better. Now I want to talk about some medication options and so some strategies for dealing with treatment side effects. And this is very sort of general, and the idea is that maybe you write something down and take it away and discuss it with your doctor. So estrogen deficiency symptoms can cause a range of symptoms. So hot flushes, night sweats, sleep disturbance, joint pains and fatigue, dry and itchy vaginas, anxiety and mood changes. So these are significant issues, and for some people, they will compromise their ability to continue with their treatment and they feel like they want to come off because the symptoms are so bad. There is a bucket load of stuff that we can do, and there's a lot of research. So we know that when we stop estrogen, so whether or not you go through menopause because of surgery or chemotherapy or radiotherapy or normal biological aging, dropping estrogen levels interferes on neurotransmitters. So you've got hormones that work on your brain, and then you've also got the chemical messengers, which are called neurotransmitters, and they both work on sending messages to your brain about how your body's feeling. If you mess with the estrogen and drop the estrogen, then it mucks up what happens with the adrenaline, the serotonin, the noradrenaline, dopamine. And so your temperature control, the thermostat goes haywire and you feel like you're standing in Mission Beach. And I'm putting my arms up so that I can get some air here. And so knowing that the medications that we ordinarily use for treating depression and anxiety work on those adrenaline, noradrenaline pathways means that we can cheekily use the side effect of that medication, which is designed for a different purpose entirely, but this stuff happens in medicine all the time. Biggest example, Viagra. Viagra was not designed for penises originally, it was designed for lungs, it was designed for pulmonary hypertension. Lo and behold, they found out as a side effect when they were using it in clinical trials that all of these things were popping up. So, same thing goes on here. So we're harnessing a side effect. We're not secretly trying to say, we think you're a bit depressed, so we're going to sneak a medication in while you're not looking. That's not how we work. Thank you. So these medications will reduce hot flushes by about 50 to 60%. So not 100%, it's not an absolute, but it certainly can help with reducing the severity and the frequency so that you can get some sleep and then hopefully be in a better mood. It's just as effective in people who are taking tamoxifen, aromatase inhibitors, or have gone through a biological or natural menopause. We use a very low dose range though. So when we're using venlafaxine, which is sometimes called Effexor, to treat depression or anxiety, we use it in doses like 150 milligrams to 300 milligrams. When we're using it to treat hot flushes in menopause, we use 37.5 milligrams. So a sniff, a drop. It is not going to work on anxiety at that dose. It's working on hot flushes. And the weird thing about these medications is that the higher the doses go, the more likely you are actually then to give people hot flushes. So the dose range needs to remain small. So desvenlafaxine, 50 milligrams. If you're treating depression, it would be 150. Escitalopram, 5 milligrams. Full dose of that is 20 to 30 milligrams. So we are really talking about low doses. You need to make sure that always when you're talking to your health professional about medications, you let them know everything that you're taking, including something that's maybe been prescribed by a GP or a different doctor, because there can be interactions. And, you know, if you're taking anything that you've bought, when I was training, we always said, you know, did I buy anything over the counter or in the pharmacy? Now we had to add in, did you buy anything over the internet? Because it's amazing what people will take that they've bought over the internet, and I'll say to them, so what's in it? And they go, I don't know. And I go, ah. So I know everything that's in Effexor. I can tell you, I could bore you senseless about Effexor for about 90 minutes, but you don't want to take that, but you want to take this stuff that... So talk to your doctor about what you are taking so that we're not causing problems with interactions and we're maximising things. Gabapentin is a medication that was originally designed for treating seizure disorders, so epilepsy. And in low doses taken at night, it can help you to sleep and it can help with hot flushes. All medications will have side effects. There is nothing that doesn't have a side effect. Not taking a medication also has a side effect, which, you know, is another way to think about it. So we start low dose and go up to maybe about 300 milligrams. For some people, it can cause some weight gain, and it causes weight gain by increasing appetite. So, you know, if you're feeling like you need to eat pavlova at 3 o'clock in the morning, resist that urge. Try and ignore it. Maybe have an apple instead. It can also make you a bit sedated. So often with these medications, you need to take them earlier in the evening. So not just before you go to bed, like maybe about 6 or 7 o'clock at night. Pregabalin is a related drug. The research for that hasn't been very promising. Clonidine is an old-fashioned blood pressure medication, and we use that for hot flushes, particularly if there's a real feeling of panic that comes with a hot flush. So some people, it's the sweatiness, and for some people it's this sense of impending doom that something bad is going to happen, and that's where the neurotransmitters and the hormones are playing around. And so the clonidine can be really helpful for that. It can cause low blood pressure, so if you're already on blood pressure medication, we need to be mindful, and it can cause some dry mouth and constipation and sedation. And everyone's a little bit different in terms of how they tolerate this. So if you were, say, someone who had a tendency towards constipation, this might not be the first medication that I would, you know, discuss with you. So we try and work out what it is that you need us to help you with, what are your particular sensitivities, and how we can best avoid that. Oxybutynin is a medication that we use to treat overactive bladder, but it's very good if there's a lot of sweatiness with your hot flush. So if you're dripping with sweat, then oxybutynin in a low dose, again lower than we use to treat overactive bladder, so maybe 2.5 milligrams in the morning and maybe 5 milligrams at night, so that can be very helpful. And if you've got overactive bladder, then two birds with one stone, right? So you're sleeping through the night because you're not getting up to pee all night, and you're hopefully not as sweaty, so that when you do wake up, you don't have to get up and change the bed linen. Side effect can be dry mucous membranes, so dry eyes, dry mouth, dry vagina. In terms of non-pharmacological strategies, so non-medication options, cognitive behaviour therapy helps to reduce the distress that you experience with a hot flush. Hypnotherapy reduces the severity and the frequency. Hypnotherapy is not about making you dance like a chicken. Right. It's about a fast-track relaxation approach, so that as soon as you hear words, you are quickly transported to a state of relaxation. Right? That's all it's designed to do. Acupuncture hasn't been found to be helpful for hot flushes, and I have yet to find a traditional Chinese medicine practitioner who will do just acupuncture and not try and sell you some Chinese medicines at the same time. So, you know, that becomes problematic. Relaxation on its own is great for your general well-being, but it doesn't specifically deal with hot flushes. Yoga is good for flexibility, good for your balance. This is important for protecting your bones because you need to be able to protect your bones by making sure you don't fall over in the first place. So the Tai Chi, the yoga, great for that. Doesn't actually do anything for the hot flushes. Hot yoga, by the way, is an aberration and should never be done by anyone. Exercise, we know, is important for well-being, mental health, and I went to a psychiatry conference in 2019, and the hot topic of conversation was the importance of exercise. That took precedence over conversations about medications. And we know that exercise reduces the risk of recurrence. Insomnia, I think that this is probably number 2 on the hit parade of estrogen deficiency symptoms. And it's interesting when you prepare talks like this and you read all the literature and the research, and they say, pharmacotherapy shouldn't be the sole treatment, so don't just give people tablets. Talk to them about sleep hygiene and talk to them about a good routine at night. And yeah, you're shaking your head, and lavender oil, and yeah, that's exactly what happens in clinic. Because I feel like saying, whoever's written this, you've actually never sat in front of a woman who hadn't slept for a week, or who's waking up somewhere between 2 and 4 in the morning. That's kind of the witching hour, isn't it? 2 and 4 in the morning. And you're wide awake, and you're trying to work out if you smother your husband, where you're going to bury the body. And I have it on good authority from a patient of mine who works for the Major Crime Squad, more than 25 kilometres away, apparently. That's where you need to start. So just a hip tip there. So yes, while we do need to do all of that other stuff, there are some medications that we can use. And so I'm going to talk to you about that. In terms of the behavioural interventions, there's an app called Calm. Now, I don't have shares in this, so there's no, kickback. But you put it on your smartphone and it's got a range of options. So you can have someone read you a story. Matthew McConaughey. Okay, so Matthew McConaughey reading a sleep story. I use that in clinic when I'm doing IUD insertions for women as a way to relax them. The problem is the nurse is so relaxed. I'm like, wait, come on. Work with me, honey. Everyone's like, ah. So it works really, and invariably you fall asleep before the end of the story. And it's such a lovely thing to have someone read you a story. They've also got all the hippie music and the sleep music and the guided meditations and stuff. But if you just I'm going to swear here, can't be asked doing anything active and you just want someone to read your story, it's really nice. And at 2 or 4 in the morning with the noise cancelling headphones so you can't hear the husband snoring, and a nice story, works really well. Otherwise, I'd probably be under investigation by the murder squad at the moment. In terms of medication, melatonin, so that's top of the hit parade. It's cheap, it's effective, it doesn't interact with anything, but the difficulty is that it needs time and patience for it to work. So you do actually need to take it consistently. The problem is most people will take 1 or 2 doses and go, it's not working, I'm annoyed, I'm not going to take it anymore. You actually need to persist, you need to give it a couple of weeks. You can combine it with other things. So you can combine it with clonidine. You can combine it with some of the old-fashioned sedating antidepressants, again in low dose. So amitriptyline, which in big doses like 150 milligrams we use to treat depression, at 5 to 10 milligrams we use it to treat pain. So sciatic pain, toothache, headaches, pelvic pain, joint pains on aromatase inhibitors, all of that stuff. So 5 to 10 milligrams of Endep at night with your melatonin and your Matthew McConaughey, you'll be fine. Mirtazapine is another, again, low-dose sedating antidepressant that can be very helpful. Trazodone and dithiapine we don't tend to use very much these days. The occasional temazepam can also be a bit of a lifesaver, so it can be useful to have. The first aid temazepam is what I call them. So the benzodiazepines, the problem with them is doctors don't like prescribing them because your body gets used to them really quickly, so you habituate. So if you took one every night for 2 weeks, by the 3rd week it would no longer work and you'd need to take 2 and then you'd need to take 4. So that's kind of counterproductive. So these are special occasion, get out of jail, free cards. And lots of patients that I work with will have one, if they'll say, I haven't slept properly for 5 days, so I'm going to take one tonight. Or I'm going to take one on Sunday night because I've got to get through this week. Or I've got a really big meeting tomorrow and I need to make sure I've had a decent night's sleep, so I'm going to take one tonight and I know I'm going to be able to sleep. So that can be useful. Balsomera is a new medication that works on neuropeptide, so brain messages that are low in postmenopausal women. It's a new medication. We think it does help for hot flushes, but it's not on the PBS. So it's not on the pharmaceutical medical benefit scheme, so it's about $60 a month. So it's not usually the first thing that we go to. Zolpidem, that can help. Some people find that they have sort of nightmares and strange dreams on it, and so they don't necessarily like it, but it's worth a try. Again, you get used to it. Rest of it is a sedating antihistamine that you buy over the counter, and most patients are already taking it by the time they get to me. It's like Phenergan, but your body does get used to it, so that's a bit of a problem. So this is the vagina slide, because in my mind, these two things go together. And last night I was so glad I had not put any slides of vaginas up because, yeah. So the list of things that can go wrong with your vagina are actually quite long. So just because it itches down there doesn't mean that you've got thrush. And in fact, if there's no estrogen, it's probably not thrush. But you can get different kinds of thrush that are not Candida albicans. You can get autoimmune conditions of the vulvas. You can get dermatological conditions. So it's skin, like skin anywhere else. And so please see someone who will examine you. If you go and tell them I've got a problem with my vagina, or as someone once called it, the undercarriage. There's a problem with my undercarriage. Okay. Please see someone who will examine you. And if they do not examine you, ask to be referred to someone who will. Because you need an examination, you need a swab, and you might actually need a biopsy. Because just assuming that it's thrush is dangerous and inappropriate. Avoid soap, wear cotton undies. For the love of God, don't wear G-strings, seriously. It's too much friction close to skin that's delicate, that is that delicate. Lubricants and emollients are important. So Replens, Acid-Gel, Vagisil, all of those things can be helpful. Some women don't find them to be particularly helpful, but it's worth giving them a try. Lignocaine gel is an anaesthetic gel, so numbing gel. I don't think we should be numbing people so that they can have penetrative sex. That's kind of not the point. It also contains chlorhexidine, which is a preservative, and an alcohol base, which is drying. So that's a no. There's a brand of lubricant, I don't know why they called, I don't know how they came up with the name, but it's called Yes. Like as in yes with an apostrophe. I didn't write that there. That doesn't mean I think it's good. That's actually what it's called. Silicone or water-based lubricants. Vitamin E oil in an ointment base can be helpful. Reverie is a hyaluronic acid, so it's a moisturiser that's in a lot of facial cosmetics. You can get that in a pessary, and you buy it online from the US. Wine is not the solution. So if your doctor says to you, you'll be fine, just have a glass of wine, dear, and relax, get a new doctor. Or feel a bit sorry for their wives, because if that's all they've got for foreplay, then I kind of feel sorry for them. The American College of O&G has a statement that you can download and read yourself, and I always give this to patients when we're discussing the pros and cons of vaginal estrogen. It's about 2.5 pages long, and it is a description of all of the evidence about whether or not using vaginal estrogen is okay or not okay. Overwhelmingly, the evidence is that yes, it is okay. Use the vaginal emollients first. I often use them for 2 or 3 weeks before starting vaginal estrogen. But so far, the available data does not show an increased risk of a recurrence of breast cancer in women using vaginal estrogen according to the standard instructions, so low dose. But vaginal estrogen is not just about sex. I once had a crusty old surgeon say to me, oh, well, I can't believe that this woman is risking her life just for sex. And I thought, okay, you're kind of missing the point about sex here. It's, it is about intimacy and connection. And if that is something that she wishes to pursue in her life, it is not your place to judge. Nor it is our place to judge if people decide that having an intimate relationship is not something that they focus on. And an intimate relationship doesn't necessarily have to focus on penetrative sex. But we do need to be mindful that vaginal estrogen is not just for pleasure, it is also for prevention of pelvic floor difficulties and urinary tract infections. So in order to ensure that we don't leak a little bit of wee every time we cough or sneeze or jump or exercise, vaginal estrogen and pelvic floor physiotherapy can be really important. There has been an increased use of lasers, so technology from cosmetic medicine extrapolated to vaginal health. So this is the vagina rejuvenation clinics that, someone's making a face like, totally. Not FDA approved, not TGA approved, not on the PBS, and the data does not support an improvement. So while the skin looks better if you take a sample of it and look at it down a microscope, it hasn't translated into a functional improvement. And $800 3 times a year, I'd expecting a little bit of functional improvement. Thanks very much. This is a paper that Michelle co-authored, and so we are also looking at the potential for using intravaginal testosterone cream for women who are on aromatase inhibitors. And the reason why we use this in aromatase inhibitors, so tamoxifen blocks estrogen. Aromatase inhibitors stop the conversion of estrogen in our bodies. So actually we make testosterone, women make testosterone first and convert it to estrogen. But if you give testosterone to someone who's on estrogen, because there are testosterone receptors in the vagina that also support good sexual function, then you can improve the pain and the dysfunction and the difficulties of dry mucous membranes and painful sex by using a little bit of very low dose testosterone in women who are already taking a aromatase inhibitor. So if this is something that you are interested in, then you need to ask your doctor about the paper that was published in 2018 and talk to them about whether or not it might be right for you. And you can find it on PubMed. You can find the abstract and take them in the abstract and say, hey, I read this. Have you read it? What are we going to do? Olive and bee, there are some samples of this available for you today. It is an olive oil and beeswax lubricant, and I think of all of the products that are available on the market, it's the cheapest, the simplest, and the best. You use it internally and externally. It's like a downstairs chapstick. It's for downstairs lips. Same principle. Seeing a pelvic health physiotherapist can also be really helpful because it can help to overcome some of the overactivity of the pelvic floor. It can help to overcome some of the anxiety about penetrative sex so that you know that your body's going to be able to manage. And my final slide, this book by Tess DeVries is absolutely fantastic. She's an occupational therapist, so a very practical approach to how do you have conversations about sex while you are having treatment. The little image in the middle is also a document that you can download from the internet that talks about all of these medications, but not in the 181 pages of the original document. Because if you want to read 181 pages, it'll probably help with the insomnia. But this is a fast track way of doing it. Thank you.